Formerly known as multiple personality disorder, dissociative identity disorder is a complex chronic condition that is thought to originate consequently to childhood trauma. It seems to be what happens when someone's identity is fragmented and not unified, and they present with different personalities in the same body. You've probably seen some representations of it in movies or on the media, but in this video, let's do an evidence-based assessment of everything to do with dissociative identity disorder. We're going to talk about the clinical manifestations, so the signs and symptoms, the epidemiology, so how common it really is. We'll talk about the pathogenesis or the cause of the illness, and finally, we'll also address the course of the illness or what to expect over a patient's lifetime. So if that sounds good, let's get into it. Now, before we get into the actual signs and symptoms or the clinical manifestations of dissociative identity disorder, I wanted to do a quick intro. My name is Dr. Sil. I'm a junior doctor from Sydney, Australia, and I work as a psychiatry registrar. So I'm going to start on the psychiatry training program in February, and I love making mental health videos whenever I get a free second. If this channel sounds like your cup of tea, consider subscribing. All right, let's get into it. Now, in terms of the core feature of dissociative identity disorder, as per the DSM, the Diagnostic and Statistical Manual, that is the manual that psychiatrists use to make diagnoses in mental health. As per that manual, the key feature of dissociative identity disorder is 2 or more personality states, as well as episodes of forgetfulness around your autobiographical memory. This means that if you're in one personality state, let's call them Sam, Sam might have gone to the shops, might have gotten into a fight with his girlfriend, and then if Sam switches into the other personality state that's in Sam's body, and let's call that person Greg, Greg would have forgotten about the fight, would have gaps in his memory of what Sam had gone through. And the fascinating thing about dissociative identity disorder is that when Sam becomes Greg, it's not just the name that changes, it's all these attributes, their identity, their personality, their affect, how they look, their mood, their quirks, sometimes even their accents. Now, often it's more than just 2 personality states, often it's between 5 and 10, as per these 4 studies that looked at over 400 patients with dissociative identity disorder. And often one of these personalities might be the kind of personality that experienced the trauma. And we'll get into the cause soon, but it's essentially thought of as most, if not all, dissociative identity disorders kind of stemmed out of childhood abuse as a kind of defense mechanism, so that personality A was the one who suffered the abuse, and personality B, when the abuse was over, personality B could get on with life. Usually the main personality state, the person that predominates, is probably the personality that experienced the trauma, and so it could be a kind of childlike, emotional, labile individual who might not be as mature as some of the other personality states that have been able to mature. Now, in terms of the people who have dissociative identity disorder and other people who call themselves plurals, which might not fulfill the criteria of a disorder because it doesn't affect their functional impact, but still find themselves having multiple personality states, and I'll do a video about plurals another time, but this is about DID. Now, in terms of the subjective experience of people with dissociative identity disorder, they really do feel like it's different people in the same person. It's not that Greg can be Sam, it's really that Greg and Sam are 2 different people taking turns of being in the body of body X. Conversely, the way to treat this in psychotherapy and the way to conceptualize it is that these are different states of being of the same person. You are in one form, and the brain and the identity in the brain has been fragmented because of trauma, and the goal is really to unify these fragmented parts when you do therapy, and that takes a long time, and then you have to be very careful to not re-traumatize unnecessarily and things like that. So it requires expert assistance. But I guess there's a disconnect in terms of people who suffer from the disorder really feel like different people, whereas psychiatrists, when they address the issue, try and look at it as different states. And personally, I've had that experience where I've dealt with people with dissociative identity disorder, and they have kind of the happy one and the sad one and the angry one and the kind of, one of them was the work one, the one that just does the walking between places, and this kind of symbolizes how it's different states of of a person, that like it's an emotional state of being sad was one of the personalities, but the person experienced it as a totally different person and doesn't remember very well what that person was doing. So there's some kind of lack of recall there as well. So let's list off some of the common symptoms that you get with dissociative identity disorder. They include things like amnesia, as we've said before, when one personality does something, the other personalities might not remember it. They include depersonalization. That's essentially the feeling like you're not in your body, like you're watching yourself from outside. You can also get derealization, which is a bit different to depersonalization because it might feel like the world that you're in isn't real, like you're in a video game or like you're in a TV show. You can also get a trance state or a fugue-like state where you're in this dissociative kind of trance and you feel like your movements aren't actually being controlled by you, but like you're a puppet being controlled by something else. And these symptoms are really associated with the dissociative nature of the disorder, where people kind of disconnect from their body and their self, really. Some people also report auditory hallucinations where they hear voices, and sometimes it's optional and they can hear the voices of the different personalities talking to one another. I've spoken to patients who, they might have a sad personality in them, and I'll ask them, why is that personality sad? And they'll say, let me just ask. And they'll be like talking to that part of themselves, but technically they don't think of that person as themselves. But they'll be talking to that person, and they'll come back. That person is sad because of X, Y, Z. Now, it's important to distinguish these voices from psychosis. Okay, this could be an autohypnotic phenomena, which is to say that it's not a psychotic process that you might see in mania or schizophrenia. It's a dissociative, post-traumatic kind of phenomena that wouldn't be fixed with antipsychotics specifically. Now, it's important to appreciate the symptom of suicidality because it's the most lethal one, and up to 80% of people with dissociative identity disorder have attempted suicide. So that's just ridiculously high. And importantly, you need to be culturally aware when discussing this with patients because, for example, if someone is in a religious kind of culture, the dissociated states could be described more like a possession, like they're being possessed by a different personality or a devil or a demon or something like that. And as far as I'm concerned, doing an exorcism wouldn't be that effective a treatment for dissociative identity disorder. So it's important to keep your cultural awareness present. Now, in terms of the epidemiology of the illness, it's approximately 1% of the community. Obviously, the numbers are higher if you look at different samples, such as mental health inpatients. But yeah, it's about 1% generally, which is quite high, 1 in 100 people having it. It can go unrecognized for a long time, and the average age of onset is about 31 years old. And there's basically a 9-to-1 ratio between females and males with the disorder. Now, it's very common, unfortunately, to have comorbidities with dissociative identity disorder. In mental health, it's very often that multiple diagnoses are the rule rather than the exception. And common mental illnesses that are associated with dissociative identity disorder include depression, PTSD, substance abuse, and personality disorders such as borderline personality disorder or avoidant personality disorder. Now, I've made some other videos about these illnesses on my channel, so feel free to go check them out. But for now, let's get on with the pathogenesis or the cause of the illness. Now, at this point, it's important to appreciate that the diagnosis of dissociative identity disorder is controversial, and not all psychiatrists agree that it's a true phenomena. The pathogenesis is unknown, but some people have conceptualized how it could come about. The main model on the thinking around how it could present is a stress diathesis model. And this essentially states that you have a diathesis, which essentially means a predisposition, so a genetic predisposition to developing the disorder. And it's usually a polygenetic thing. There's lots of different genes that increase your risk, but none that dictate it. There's no 100% you have this gene, you get this disorder. But then you can also have these genes and not get it, and that's where a stressor has to trigger it. So that's the diathesis is the genetic predisposition, and then the stressor is the thing that triggers the predisposition to the disease to turning into a actual disease. And the stress, is very commonly up to 100% of the time in some studies, childhood abuse, usually childhood sexual abuse, and often repeated. wounded. And so the child has an immature defense mechanisms because they're a kid, and so they just need to survive, as all animals try and do in traumatic situations. And so their defense mechanism is to dissociate and to essentially pretend like there's someone else whilst the abuse is ongoing, and then when the abuse finishes, they can go back into a different state, and then they can kind of separate themselves from the horrible things that are happening to them. That is very hard to untrain afterwards, because it's very hard to convince a child that they're safe after such a horrible thing. And so very significant risk factors are, of course, childhood trauma. The most commonly reported stress postulated in the stress diathesis model is severe childhood physical or sexual abuse, as I said. But can also be emotional or verbal abuse. Now, this can be very difficult if there's poor infant attachment with their caregivers, especially if it's the caregiver causing the abuse. Like, you can imagine if you're a child, you are dependent on caregivers. But if it's the caregiver that's also abusing you and caring for you, you have this very conflicting situation. And so you have these two states of caregiver where they are the carer and the abuser. And so it makes sense for you to split your identity so you can match their state. If they're abusing you, you can go into personality B, and if they're being kind and caring or giving you food or whatever, you can go into personality A. That's how it's conceptualized. Now let's talk a little bit about the course of the illness. How long should it last for? And unfortunately, there's not much data here, which is often the case in these rarer mental illnesses. It's thought to be a fluctuating, typically chronic mental illness. So it might have times where it's more severe in intensity and in episodes of switching between personalities, especially if you're going through a tough time or a stressful time as an adult. You might regress into the defense mechanisms that you learned as a child, as we all do. But if you're going through an easier time, it might not be so severe. So it can be a fluctuating course, but it's going to be chronic unless you get psychotherapy and mental health assistance in helping you. Now, important things to tell to your doctor. You need to tell them if you have periods of time you can't account for, if you have any knowledge or memory of those periods, what you've been told about what you were doing during these periods, and if it's different to your normal personality. Make sure you let them know if you're doing any drugs or alcohol. That could also explain these dissociative periods, because yes, drugs like ketamine can do this. Are you getting these symptoms we talked about before, and is there any known trigger for them? Like, is it, for example, whenever your parents come over, you derealize and you feel like you're in a video game? Always have to talk to your doctor about suicide and history of attempts or thoughts. You won't be in trouble, but you do need to talk about it, okay? As a reminder, you cannot diagnose yourself based on YouTube videos. There are so many mental illnesses that can look like a dissociative identity disorder and require very subtle investigations by a trained psychiatrist. This video is just to educate, empower, and basically train you up to ask better questions with your doctors so that you can save time and be better educated when you talk about the different possible diagnoses for you or your loved one's condition. If you think you need help, please just get to the door of your GP or your family doctor or your psychiatrist. Just get to the door. You don't need to worry about what to do. They'll do the talking. They'll ask the questions. All you have to do is be honest. And I wish you all the best. That is it for this video. If you found it helpful, please consider subscribing. If you want to learn more about mental health, check out this playlist. And I wish you all an absolutely wonderful day. See you in the next video.